I would like to tell you about my work, starting with a story of a patient, which is why I do what I do every day. A 40-year-old woman, she has 2 young children, and she had come in for a screening mammogram somewhere else in town. And they had done the screening mammogram and found that she had a very small group of calcifications, something less than a centimeter. And so they had called her back so she could get a workup done. And, in there, about a week after her screening mammogram, she had come in, got her images done, and she was told appropriately so that she needed a biopsy. And then she waited another week, got a biopsy, and was told that she has ductal carcinoma in situ, or a primary form of breast cancer. At that point, she was then sent to us in our practice to see a surgeon and discover the extent of her disease, which she had been told should be, very simple, because this was a very tiny area of cancer and it wouldn't be a problem. She would get treated quickly and back to normal. When she came to see us some, 3 to 4 weeks after her initial screening mammogram, we, of course, wanted to look at her breasts with the knowledge of the biology of what was going on. Because this was a young woman, she had dense breasts, she had implants in place, and so it's important for us to figure out what the biology is by using contrast imaging. And for us in clinic today, what's in use is contrast MRI. We did this exam only to discover that half of her breast fully was involved with the breast cancer. So far, far more extensive than that little tiny group of sub-centimeter calcifications. This, of course, has now brought us to maybe a month or a month and a half after she started this journey. She required chemotherapy, and she required imaging during the chemotherapy on to the time that she was able to get surgery and get her treatment completed. But one of the things that us breast imagers deal with every day is this shortcoming of screening mammography, as is demonstrated in this patient's case. We know that screening mammography works. We know that since it started in the 1990s, deaths due to breast cancer have dropped by over 40%. And there are mountains of data showing that it works. However, there are limitations to mammography, and there are particular groups of women that have these limitations that we have to overcome as breast imagers in order not to miss breast cancer. Some of these limitations are that there can be things that sort of look like breast cancer, but indeed there aren't breast cancers. And so you spend hours, days, weeks working with women to make sure that what you see on that initial imaging exam is actually nothing, so that she can then spend the next year until her next screening mammogram in peace. Then there are those awful cases where we look at the screening mammogram, there's nothing that's showing up, and it's a cancer that is not showing up on the mammogram. And so she comes in sometime later and we discover that the mammogram just didn't pick up that breast cancer. This is particularly important for women who have dense breast tissues. That's up to 50% of women in the United States who may have dense breasts, and that's just because they have a higher proportion of breast tissue in comparison to the amount of fat that's within their breasts. Cancers can hide in that tissue for imaging with screening mammograms, and so we could easily miss it. Cases like this are the reasons that we started our research in breast cancer searches with breast CT. This moment has been a long time coming, and what I hope can happen is the last step that is necessary for us to be able to share with the world why we are so excited about imaging women's breasts with breast CT with contrast to save lives from breast cancer.